Lurasidone in schizophrenia, efficacy, metabolic profile, and clinical use. Schizophrenia affects approximately 0.3% of the global population, with significant morbidity linked to dopamine D2 and serotonin 5-HT2A receptor dysregulation. Lurasidone, a second-generation antipsychotic, demonstrates robust efficacy in reducing positive and negative symptoms with a favorable metabolic profile compared to other atypical antipsychotics. Diagnosis relies on DSM-5-TR criteria requiring greater than or equal to 2 symptoms, e.g., delusions, hallucinations, persisting for greater than or equal to 6 months with functional decline. First-line treatment includes lurasidone initiated at 40 mg per day orally with food, titrated up to 80 to 160 mg/day, combined with psychosocial interventions to improve long-term outcomes. Key points. Note: lurasidone is FDA approved for schizophrenia in adults and pediatric patients aged 13 to 17 years, with initiation at 40 mg per day and maximum dose of 160 mg per day. In clinical trials, lurasidone demonstrated a 30 to 40% reduction in positive and negative syndrome scale, PNSS, total score versus 15 to 20% with placebo over 6 weeks. The incidence of weight gain greater than or equal to 7% from baseline with lurasidone is 2.5 to 4.0%, significantly lower than olanzapine, 22.6%, or risperidone, 7.8%. Fasting glucose levels increased by a mean of plus 1.2 mg/dl with lurasidone versus plus 6.4 mg/dl with olanzapine in 6-week trials. Triglyceride levels rose by a mean of plus 4.3 mg/dl with lurasidone compared to plus 28.7 mg/dl with clozapine in head-to-head studies. Lurasidone has a QTc interval prolongation of plus 4.6 milliseconds at therapeutic doses, below the 10 milliseconds threshold considered clinically significant by the FDA. The drug must be administered with at least 350 kilocalories of food to achieve adequate bioavailability, increasing absorption by 3-5-fold. Lurasidone is contraindicated in patients with known hypersensitivity and in combination with strong CYP3A4 inhibitors, e.g., ketoconazole, or inducers, e.g., rifampin. In elderly patients with dementia-related psychosis, lurasidone increases mortality risk by 1.8-fold, consistent with a class-wide black box warning. The number needed to treat, NNT, for lurasidone versus placebo for response, greater than or equal to 20% PNSS reduction, is 6.3 over 6 weeks, with a number needed to harm, NNH, for akathisia of 11. Lurasidone shows minimal prolactin elevation, with only 2.1% of patients experiencing hyperprolactinemia, prolactin greater than 20 nanograms per milliliter in males, greater than 25 nanograms per milliliter in females. For bipolar depression, lurasidone is approved as monotherapy, 20 to 120 mg/day, or adjunctive therapy with lithium or valproate, 20 to 80 mg/day, though this article focuses on schizophrenia. Overview and epidemiology. Schizophrenia is a chronic, severe psychiatric disorder characterized by disturbances in thought, perception, emotion, and behavior, defined in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, DSM-5-TR, under code F20.9, unspecified schizophrenia. The global prevalence of schizophrenia is estimated at 0.28%, 95% CI, 0.25 to 0.31%, translating to approximately 24 million individuals affected worldwide, according to the World Health Organization, WHO, 2023 report. Regional variations exist. Prevalence is highest in high-income countries, 0.32%, and lowest in low-income regions, 0.24%, likely due to differences in diagnostic practices and access to care. Incidence ranges from 10 to 15 per 100,000 person-years globally, with a peak onset between ages 18 and 30 years. Men are diagnosed earlier, with median age of onset at 22.5 years, SD plus or minus 4.3, compared to women at 27.2 years, SD plus or minus 5.1, and exhibit more severe negative symptoms and poorer functional outcomes. The male-to-female incidence ratio is 1.4 to 1, with lifetime risk of 0.7% in males and 0.5% in females. Racial disparities are evident. African American populations in the United States have a 2.1-fold increased risk of diagnosis compared to non-Hispanic whites. RR equals 2.1, 95% CI, 1.8 to 2.5, though this may reflect diagnostic bias rather than true biological differences. Genetic factors contribute significantly, with heritability estimated at 79% based on twin studies. First-degree relatives of individuals with schizophrenia have a 6.5-fold increased risk, RR equals 6.5, 95% CI, 5.2 to 8.1, compared to the general population. Pathophysiology. The pathophysiology of schizophrenia involves complex interactions between genetic vulnerability, neurodevelopmental abnormalities, neurotransmitter dysregulation, and environmental stressors. Central to the dopamine hypothesis is hyperactivity of mesolimbic dopamine D2 receptor signaling, contributing to positive symptoms such as hallucinations and delusions, while hypofunction of mesocortical dopamine pathways underlies negative symptoms, e.g., avolition, anhedonia, and cognitive deficits. Post-mortem studies show a 15 to 20% reduction in prefrontal cortex dopamine D1 receptor density in schizophrenia patients, correlating with impaired working memory, R equals 0.42, P less than 0.01. Serotonin, 5-HT, system abnormalities are also implicated. Lurasidone exhibits high affinity for 5-HT2A receptors, Ki equals 0.5 nm, greater than its affinity for D2 receptors, Ki equals 1.7 nm, resulting in preferential 5-HT2A blockade. This action disinhibits dopamine release in the prefrontal cortex, improving cognitive and negative symptoms. Additionally, lurasidone acts as a partial agonist at 5-HT1A receptors, intrinsic activity 45% of serotonin, enhancing serotonergic modulation of mood and anxiety circuits. Clinical presentation. The clinical presentation of schizophrenia is heterogeneous but typically includes positive, negative, and cognitive symptoms. Positive symptoms, present in 85 to 90% of untreated patients, include delusions, 78%, hallucinations, 70%, predominantly auditory, disorganized speech, 55%, and grossly disorganized or catatonic behavior, 30%. Delusions are most commonly persecutory, 62%, or referential, 45%, while auditory hallucinations involve voices commenting on behavior, 58%, or conversing, 32%. Negative symptoms occur in 60 to 70% of patients and include blunted affect, 65%, elogia, 50%, avolition, 70%, anhedonia, 60%, and asociality, 55%. These often precede psychosis by years and are strong predictors of functional impairment. Cognitive deficits affect 85% of patients, with mean IQ reduction of 8 to 10 points below pre-morbid estimates. Core domains include working memory, affect size D equals 0.85, attention, D equals 0.78, processing speed, D equals 0.91, and executive function, D equals 0.72. Key points: neuroleptic malignant syndrome, NMS fever greater than 38.5 degrees Celsius, rigidity, CK greater than 1000 U/L, autonomic instability. Severe agitation with risk of harm, PNSS excitement component greater than or equal to 16. Acute dystonia causing airway compromise. QTC greater than 500 milliseconds on ECG. Diagnosis. Diagnosis of schizophrenia follows DSM-5-TR criteria, F20.9, requiring 1. Presence of greater than or equal to 2 of the following, each present for a significant portion of time during a 1-month period, or less if successfully treated. 2. Social/occupational dysfunction, for a significant portion of time since onset, one or more major areas of functioning, work, interpersonal relations, self-care, are markedly below the pre-morbid level. 3. Duration. Continuous signs of disturbance persist for at least 6 months, with greater than or equal to 1 month of active phase symptoms. 4. Exclusion of schizoaffective disorder and mood disorders with psychotic features. 5. Symptoms not attributable to substance use or another medical condition. Key points: delusions, 1 point. Hallucinations, 1 point. Disorganized speech, e.g., frequent derailment or incoherence, 1 point. Grossly disorganized or catatonic behavior, 1 point. Management and treatment. Acute management of schizophrenia focuses on stabilization, safety, and symptom control. Patients with severe agitation, PANSS excitement component greater than or equal to 16, or risk of harm require immediate intervention. First-line pharmacologic treatment includes second-generation antipsychotics, SJs, due to lower EPS risk. Intramuscular, IM, options are preferred in agitated patients unable to cooperate. Monitoring includes continuous pulse oximetry, ECG, for QTC, and serial mental status exams. Rule out NMS if temperature greater than 38.5 degrees Celsius, CK greater than 1000 U/L, or rigidity present. Non-pharmacologic de-escalation key points: olanzapine IM, 10 mg dose, onset within 15 to 30 minutes, duration 6 to 12 hours. Aripiprazole IM, 9.75 mg, single-use autoinjector, effective in 20 minutes. Ziprasidone IM, 10 to 20 mg, avoid in QTC greater than 450 milliseconds. References. 1. Miura et al. Lurasidone for the treatment of schizophrenia, design, development, and place in therapy. Drug design, development, and therapy. 2023, 17:3023-3031. PMID, 3778991, https://pubmed.ncbi.nlm.nih.gov/3778991. doi 10.2147/dddt.s3666769. 2. Fiorillo et al. Lurasidone in adolescents and adults with schizophrenia, from clinical trials to real-world clinical practice. Expert opinion on pharmacotherapy. 2022, 23, 16-1801-1818. PMID, 36398838, https://pubmed.ncbi.nlm.nih.gov/363988838. doi 10.1080/14656566.2022.214158. 3. Siwick M. et al. Lurasidone in therapy of treatment-resistant ultrarapid cycling bipolar disorder, case report. Clinical Psychopharmacology and Neuroscience, the official scientific journal of the Korean College of Neuropsychopharmacology. 2021, 19. 3568-571. PMID, 34294628, https://pubmed.ncbi.nlm.nih.gov/342944628. DOI 10.9758/CPN.2021.19.3.568. 4. Abhavana v. et al. Association of atypical antipsychotics with lipid abnormalities in adult patients with schizophrenia, a scoping review. Neuropsychopharmacology reports. 2025, 45, 4E70042. PMID, 41017289, https://pubmed.ncbi.nlm.nih.gov/41017289. DOI 10.1002/NPR 2.70042. 5. Findling RL et al. Diagnosis and medication treatment of schizophrenia in adolescents. Drugs. 2026, PMID, 421290067, https://pubmed.ncbi.nlm.nih.gov/421290067. DOI 10.1007/S40265-026-02332Y6. Siskind D et al. Does switching antipsychotics ameliorate weight gain in patients with severe mental illness? A systematic review and meta-analysis. Schizophrenia Bulletin. 2021, 47, 4948-958. PMID 335474771, https://pubmed.ncbi.nlm.nih.gov/335474771. DOI 10.1093/spool/spa191. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.